We've muted everybody, and we're going to ask you to stay muted until we move into the Q&A part. And then, of course, when you have a question, you can raise your hand if you are like most people living on Zoom and you know how to use the raise your hand feature. Go ahead and raise your hand and we'll see that. And we'll ask you to ask your question. You can also type it in the chat. Lakeisha will be monitoring the chat. And you can type your question in the chat and I might ask you to then go ahead and say it. We do want this to be interactive and a nice casual evening with Dr. Repka. The other thing that I would just remind everybody is that Dr. Repka is not your treating physician. So keep that in mind when you ask questions this evening. He will not be able to give you advice on your specific medical case or condition. So when you think about that, ask your question in a way that benefits everybody on the call. So try and keep it a general question. So as opposed to, I'll feel pressure in my eyes, it would be, is it uncommon to feel pressure in your eyes if you have hydrocephalus? So we'll keep the questions general so that Dr. Repka can answer them and everybody can get a little bit of something from all of his answers. If everybody's okay with that, let's test the raise your hand. Raise your hand real quick. Or you can clap too, if you know how to use the features. All right, I see some hands coming. Great. All right, so we know Zoom features. This is a Zoom crowd. I love it. All right, well, wonderful. For those of you that don't know me, my name is Amanda Garzon. I'm the COO of the Hydrocephalus Association. I have been with the association since 2012, and I love my job of working with two incredible women, one who is on this call this evening, Lakeisha, who you might see depending on where you are in your Brady Bunch view. Lakeisha oversees all of our support programs. And then I also work with Jennifer Bouchard, who oversees all of our education programming. And we work together to make sure that we're providing the support and educational resources all of us need to navigate our journey with hydrocephalus. Many of you also know that I have a 20-year-old daughter who has hydrocephalus. And so I'm living this experience with you. So that is me. Welcome, everybody. I have the pleasure of introducing Dr. Michael Repka this evening, who is joining us from the Wilmer Eye Institute at Johns Hopkins. He is the Vice Chair for Clinical Practice at the Wilmer Eye Institute. He's a professor of ophthalmology, and he holds the David Guyton and Viduniak Family Professorships. And so, Dr. Repka, thank you for joining us this evening, and I hope you're unmuted.
No, I've got it. Thank you very much. And yes, it's a privilege or a pleasure or both to speak with you tonight. It is, as I told Amanda earlier, far easier to do than journeying to some remote hotel ballroom somewhere that nobody really wants to do at this hour in the evening. So I was asked to talk a little bit and really to address questions that are generic to the hydrocephalus space. And of course, it is a collection of conditions. There's probably, if you have one hydrocephalus child, you have just one, because there are many, many others, and the presentations are often different. And ophthalmology is really just a part of the care of these children. I would view it as an important part, but nonetheless, just a component. And so it's a bit about a team of the pediatrician, the neurosurgeon, the neuroradiologist whom you never see, but who's really, well, actually you might see if they're wander through, if you're getting a sedated MRI or something like that. But they're really critical to knowing what's going on. And then any number of other developmental support, physicians, mid-level providers that you've run into in your experience. And there are many. And every support network seems to be a bit different. And you all undoubtedly have learned to navigate the healthcare system probably better than the average US citizen, which is unfortunately a shame, but it's the way it is.
And Dr. Repka, I also just wanted to let you know that this evening we do have individuals of all ages joining us who are living with hydrocephalus, from
Right.
parents who have infants all the way through to individuals who are living with normal pressure hydrocephalus. And so just, we can, I know that you can speak to as an ophthalmologist, you can speak across the age spectrum around these issues.
Thanks for that
Mhm.
clarity. But yes, children turn into adults, whether they have a disease or not, and you certainly have to learn to navigate that situation on your own if you're in that age group. I don't do as much care in adults anymore as I once did, but nonetheless, adults are important too. But then, of course, we have all the transition issues that those of you that have gone from being a teenager or an adolescent to an adult, and another place where the healthcare system doesn't always navigate so readily. I wanted to just share a few pictures before we went into sort of the conversation that Amanda and I were intending. And so I've put up a share screen and just a couple structures that are going to get bantied around in the hydrocephalus space all the time. And this won't be many slides that will be formal, but this is a very normal looking optic nerve. So this is what, when you ask, well, what are they looking at inside the eye? For a hydrocephalus patient, this is the structure. The blood vessels are sort of obvious to you. The slightly lighter red are the arteries, and the slightly darker red are the veins. And that donut in the middle is the optic nerve. And this is a very normal looking optic nerve, and around it is the retina. But again, the optic nerve is where the action is. And this structure is just 1.5 millimeters in diameter. So it is tiny. And so it is often very hard in the upset young person to be able to see, and sometimes why the exam is difficult, and sometimes why we can't tell. You look at a 1.5 millimeter structure that's moving around the field, even with magnification, it can be difficult. That optic nerve then feeds back toward the brain. And so this is a CT scan now cut where the brain has been sliced through the eyes and through the brain. And you can see the structure in the middle with the little yellow arrow is the optic nerve in the orbit or in the eye socket. Sometimes that gets dilated by a patient with hydrocephalus, and we can see that. And sometimes it becomes narrower or smaller or atrophic, and that could be a result of anything, including hydrocephalus, that might damage the optic nerve. The optic nerve then feeds through itself into the brain, and this is what's called a sagittal MRI, which basically means it's cut through the nose, if you will, back to the back. And this is very normal looking, and I don't think the arrow shows up, but I'll ask. Does the arrow show up there at all for you? So this is the chiasm right here, and then it spreads out, as we'll see in the next picture, which is a drawing rather than the scan. So this is an artist who has taken a three-dimensional structure and presented them here in 2 dimensions. So again, the eyeball without any surrounding structures, the optic nerve, and the chiasm is here. And then these fibers, called optic tract, come toward us. So think of them as coming at us, and we don't have any of the brain around it. And then these are what are called the radiations, or the occipital radiations. And basically, that's where the visual information is being transmitted back to the brain, or the occipital lobe. The radiations can be damaged in a patient who has enlarged lateral ventricles. They're literally sitting on the opposite side, just to the inside of the radiations. And so these wrap around and are damaged in some, or injured in some patients with that, with hydrocephalus. The occipital lobe is that part of the brain that just does vision. It's its one task. It interprets what we see and then sends signals to elsewhere in the brain for us to actually interpret. And this is just a complicated drawing that is only trying to show one thing, and that has to do with how we see the world. We're all used to that the right brain controls the left side of the body. That is, if you have an injury to the right brain, the left arm, the left leg don't work quite right, and vice versa. For the vision, it works a little bit differently, or some of you might say analogously. And so what the artist has done here is said that vision coming from the left-hand side of the left eye and the left-hand side of the right eye, which actually look at the right side of the world. So the left retinas, the left half of the retinas are looking to the right, and that goes to the left brain. So that's all the artist is showing us. So unlike the left eye going to the right brain, for vision, some of each eye crosses over so that the right side of the world goes over to the left brain and the left side of the world goes over to the right brain. So it's somewhat analogous to the motor function, but different. So we think of hydrocephalus being an important part of sensory problems for vision. And this is just one quick statement that on vision. Everyone wants to have a quantitative measure for children, and they just don't really exist very well. So quantitative measures have been tried for a long time. They do two things for us. They give us a false sense of security. Oh, they say the vision was this good. And we've seen electrical tests like VEP give these amazingly normal things that the patient is not capable of. So a false sense of too good. But they also sometimes give a false sense of bad because they rely on some reaction of the patient to the world. And some patients just are not as able to do those reactions that we expect. So we get a false sense of bad. So most of the time we end up with qualitative measures in infants and young children. And do they watch us? Do they pay attention to lights? And there are various measures that people use, none of which are perfectly calibrated to reality. You've all seen for young people using symbols as a way of measuring acuity. It's a stepping stone to letters. Now, what do we look at? Remember at the outset, I showed the picture of the normal optic disc. Well, this is the disc the neurosurgeon wants to know about, or the neurologist, which is not normal. Instead of having a nice defined little donut in the center, this one is blurry, and it's not the photography, it's the swelling of the nerve that's made it. There actually are some hemorrhages here and here that go along with the pressure is elevated in this patient's brain. So this would be a patient who has optic nerve swelling, commonly, but sometimes loosely termed papilledema. And that's because the ophthalmologist is going to be always careful to say, well, it's optic disc swelling. It's papilledema if you prove that it's coming from increased intracranial pressure. So often we leap to that connection in a patient with hydrocephalus, and most of the time that's right. But we do always have to be careful. So that's the number one sign or sign we're looking for evidence, ophthalmological evidence of increased pressure. The opposite of optic disc swelling is optic nerve pallor. And the big white spot here is an artifact of the photography, but you can see the vessels look normal. But what are we missing? The opening in the eye wall is there, but there's very little to no optic nerve substance. So a patient with optic nerve atrophy, so a patient who's been injured by any number of mechanisms. They always look the same at the end, but could be from hydrocephalus that was not treated, or that was treated and just the nerve had been so significantly injured it wasn't salvaged or saved. The other clinical finding for hydrocephalus that's gotten worse is the development of strabismus. And the picture here was only to remind us that there are a whole bunch of eye muscles that move the eyes around in the eye socket. But the characteristic finding of increased pressure is the child who has straight eyes who then becomes crossing, like we have in this patient's right eye, or the patient who used to drift out that now looks better. So a false sense of improvement. So new movement of the eyes inward is always a worrisome clinical sign for hydrocephalus. So with those, as soon as I manage it, with those sort of introductory comments about structures and things, I think Amanda and I thought we would then sort of carry on a conversation about some of the common questions in this condition.
Great. Thank you, Dr. Repka. I know it's a lot to take in. I know personally, and I don't know how many of you agree with me on this, when I go see our neuro-ophthalmologist, I'm super excited when he or she doesn't see anything, because I'm like, yes, okay, we're doing, like, everything's good in my child's brain. So I don't know if you guys have ever experienced that elation. It's really fun to go to the neuro-ophthalmologist for us, because I feel like it's a second non-MRI invasive way to let me know if something's going on inside my daughter's head.
And I should say that is certainly part of teamwork, to be able to figure out how to schedule the MRI scans or CT scans or ultra fast MRIs at a interval, so that the eye exam occurs not always with it, but at sort of to cut the difference in timing, to give you that sort of extra safety measure. You know, I don't add a lot if they do an MRI and not much is going on, but I can add a lot in between MRIs if something's going on.
So Kimberly asked a great question, and it was one of the questions that you and I spoke about, Dr. Repka, when we were preparing for tonight. And that's really, what is the difference between an optometrist, an ophthalmologist, and a neuro-ophthalmologist? And who should be on our team? Is there a right or wrong way to go, or not necessarily right or wrong? Is there some, what should our team look like in terms of eye care? And does it change over time, right? Or should we always be seeing the same type of eye doctor?
It almost certainly will change over time as the clarity of the situation for a particular patient's disease process is clear. So many of you probably know, but an ophthalmologist is a medical doctor, so trained with medical school, then 4 years of residency. And most ophthalmologists today do an extra year or two of fellowship. So it's around 9 to 10 post-baccalaureate years of training for ophthalmologists. They will specialize in different parts of ophthalmology, and they will range in expertise, that is acquired expertise from ongoing experience. That I'm only interested in seeing geriatric patients who need cataract surgery, or I only do retina surgery, or I see the whole gamut of ophthalmology and I do cataract surgery perhaps, but I can examine the patient and then triage as appropriately. And that's going to become sort of personal preference for what the clinician has decided to do. Some ophthalmologists will specialize in neuro-ophthalmology, and that's usually a 1-year post-residency training program. And they will do anything that has to do with the brain and the eye. So that might be optic neuritis, that might be, God forbid, headache, that might be strabismus or eye muscle things, that may be the eye manifestations of brain tumors or other inflammatory conditions of the brain that manifest in the eye. Now, the odd thing about neuro-ophthalmologists is they can come out of ophthalmology, and perhaps a third do today, but more actually come out of neurology training. And that's been a trend over the last 3 decades that you'll see more and more neuro-ophthalmologists who have trained predominantly in neurology as their background, and so they're not surgeons. And that's, again, what is happening. It is regional, but it is something to know about the particular neuro-ophthalmologist, if that's whom you're seeing. In general, they sometimes do long-term care, but not all of them do long-term care, that they sometimes want to be consulted every time there's a problem from the primary care team. But others do annual follow-up or every 6-month follow-up until they retire. An optometrist comes to eye care from a different route. They are also post-baccalaureate, 4 years of optometry school. It's designed more to be primary eye care, that is eyeglasses, minor eye conditions, but are not doing surgery. Some of them will be absolutely comfortable with some routine neuro-ophthalmic conditions, and a handful have done now residency training in neuro-optometry, as it's called. So I guess I would say you almost have to know who the people are on your team to decide who, in fact, is the right place to be. And of course, that's typically when you start who the neurosurgeon sends you to, because you're not exactly in a place to choose who or what. And in some HMO settings, of course, it will depend upon where you're allowed to be seen, the usual in-network versus out-of-network issue. But I guess the one thing you don't want to be is in a situation where your feeling is that they haven't seen a hydrocephalus case in their career or since they were in training. And usually, most parents can learn to read those responses pretty well from the clinician. So again, ideally, if there were a neuro-ophthalmologist for everyone, that's great. There just are not that many in this country or anywhere in the world. And certainly if you live in some parts of this country, you're probably talking 300 to 400-mile drive to find one. So they're out there. They all can help to the best of their expertise, but unfortunately, you need help finding out who that should be. And certainly in our system, as in most systems, that's the neurologist that's caring for you or the neurosurgeon usually can be helpful.
Wonderful. And am I incorrect or correct in saying that optometrists do not perform surgery and ophthalmologists do? Or is that incorrect?
Optometrists are not surgeons. That's right. There are a couple places in the country they can do some very limited eyelid procedures and a laser in Oklahoma and in Iowa. But it's, whereas ophthalmologists are physicians and hence come out of a different route. And so we spend much of our residency doing surgery as well as patient care. Okay.
And, earlier as we're talking about the doctors that treat our loved ones, as well as, and that could be neurosurgery, neurology, neuro-ophthalmology, ophthalmology, particularly for parents who have young children, there's a lot of patching that takes place. A lot of parents and maybe even people who are on this call who have hydrocephalus have patched one eye or alternated. And I'm curious, I'm thinking about strabismus now. And I know that often before strabismus surgery, they'll recommend patching. And then also sometimes people have asked us about vision therapy as well. So I know that that's kind of 3 questions in one. Maybe we start with patching and strabismus, and then are there other doctors or types of therapy that can help that are holistic that might prevent surgery, strabismus surgery, for example?
Okay, so let's start first with the polite names for the conditions. So, and again, they vary a little bit where you are, but lazy eye is the synonym for amblyopia. And you can see why lazy eye became more popular. The lazy eye is referring to the vision is lazy, not the eye muscles. And that's where the confusion typically comes. So it's the vision in one or both eyes is reduced. And that can happen from a number of mechanisms in the patient with hydrocephalus. First, they can have the regular cause. The most common cause is actually uncorrected refractive error. And no child with hydrocephalus is immune to having that. So that the eye care provider before needs to say, is that what was going on? And you correct with glasses. Patching is the second tier treatment after glasses. The idea is that the vision is reduced in one eye. Can we make it better in that eye by making the child use it? And that sounds intuitively logical. And at least under normal circumstances, you can, with patching, improve the abnormal eye, usually to within about 2 lines of the good eye. On average, we do not make the eyes equal. We make the bad eye better, but doesn't quite make the same level. The problem in hydrocephalus patients is that there could have been damage to the optic nerve from the pressure before it was treated, and so that the vision potential of the eye with the reduced vision may not be what we assumed it would be. And thus, we don't ever want to keep patching a patient with hydrocephalus forever. In other words, you have to say, they didn't respond to the patching in 3 months or 4 months or 6 months. Don't make that parent and don't make that child keep doing patching because they haven't made it. Accept the fact that they have multiple reasons why the vision isn't improving. And you try to improve, but you don't go on and on as you might do in an otherwise normal neurological history patient. Vision loss from amblyopia in 2021 is not correctable in older patients after the age of 12 or 13 years. There are any number of gadgets being sold online that suggest that you can treat amblyopia successfully in older patients. There's no study to show any of them have actually succeeded when you compare to a comparison group. So there are, as always, lots of solutions, not always necessarily bona fide, because to be honest, everyone wants their patient, their son, their daughter, themselves to get better. So there are some other treatments for lazy eye or amblyopia with eye drops that we will do for the patient who won't tolerate the patch. It's a dilute solution of atropine. It causes the good eye not to work so well, makes the bad eye work. It turns out it works just as well as the patch, but not every parent wants to give their child a drop every day or several times a week. So often parents will opt not to do that. So that's amblyopia or lazy eye. I should say, there are new gadgets on the market today that if you search amblyopia, you will find that to treat your young child. None of them marketed also has a trial that shows they're any better than doing nothing, which may seem horrifying, but it's the reality that you have a device that doesn't damage anybody. Often it can get on the market with a claim that's probably not bona fide. And if they have the right lawyers write the right caveats for the patient, they can still sell the product. So we are looking at some of those to help regular amblyopic children, but we don't know whether they would work in this group or not. So that's lazy eye or amblyopia. But that gets totally confused with strabismus, which is basically the generic term for any eye muscle misalignment. So if you happen to be in the United Kingdom tonight or in Australia, you would call that squint. But for whatever reason, that term never turned out to be acceptable in the US 100 years ago. Even then, I guess we were careful to, or more careful than they were to tell it like it is in the UK. So strabismus is any misalignment. It can be in, it can be up, it can be out. And children with hydrocephalus get them all. And they get them all because during their episodes, before the treatment, part of the area of the brain that can be affected is around the fourth ventricle. And many, many children have either non-communicating hydrocephalus or one of those forms that causes dilation of the fourth ventricle. And a lot of the eye motor control nerve cells are right underneath that fourth ventricle. And so they could have been pushed on and damaged. And just depending on the balance of the injury versus how much it recovered, you get any number of misalignments. Now, what happens if you're misaligned? Well, the eye that you don't use, because the child's brain, unlike the adult brain, knows to use one eye and not see double, which may seem like totally logical, but how it ever learned that is amazing. So that a patient who has a strabismus as a child, even when they grow up, they still retain that ability to suppress the deviating eye and not be bothered. Great. But our job is to try and figure out how to get the eyes to work together again so that they can improve their depth perception, which they lose when they deviate. The worrisome deviation direction I mentioned with the slides was inward. So a patient with the history of hydrocephalus who develops a new crossing of the eyes or amazingly improves drifting out of their eyes, you have to think the pressure's gone up, because one of the things pressure in the brain does is it causes the eyes to move toward each other. And we don't know really why that happens. It may be stretching of the nerves that run the outside muscles, and so they get weak, and so the eyes toe in a little bit. Strabismus is treated in a patient with a history of hydrocephalus by, number one, making sure the pressure is under control. Number two, checking again to make sure the pressure is under control, because that's the one thing that could hurt that patient as well as help the eyes. So that that needs to be done. Once that's done, you need to wait a long time for recovery, a year or so, because these children change just as the adults change later in life. They just change more slowly. And then if the deviation is small, you do nothing, because there's just too much variability and the surgery is not likely to make them perfect. For very large deviations, you will do or offer surgery. The decision to do surgery will depend upon the child's other medical problems, or I should say both children and adults, whether there are other medical problems or if they're well controlled, whether there's an aesthetic blemish, whether there's a functional deficit. And all of those are weighed very differently by every family. They will have different levels of concern about each thing. So I do think that it is dangerous to have a formula of one size fits every person, because it really doesn't in this space. You asked, Amanda, at the beginning, whether or not there are any eye exercises or vision training that help. And the long answer is we don't know, which is also the short answer. Vision therapy has really only been subjected to one clinical trial in a totally not the same issue condition called convergence insufficiency in teenagers and young adults. And there it actually did show evidence of working. The problem is, like many of our therapies, we don't have enough information in this space to know that it works or doesn't work. So we can say we don't know. It costs a lot of money and we still don't know. And it needs to be studied. The biggest problem I have with the studies is designing the study because the patients are so variable, it makes it hard to generate an endpoint. But just saying this means we need to look again at that. Surgery would also be more acceptable, I think, to many parents and to adults if it was one and done. But unfortunately, it's not one and done. When we lose binocular vision, when our eyes deviate after we're 3 or 4 months of age, I should back up and say, when we're born, infants can do anything they want with their eyes, up to about 6 months. Typically, they do some crossing, they do some turning out, and that gets less and less frequent until 6 months, and it shouldn't really happen much at all after that, or there's an abnormality. But hydrocephalus, if it's congenital or early onset, disrupts that normal progression. And once disrupted, we can't make it better. We, the doctors, you, the parents, you, the patient, there's nothing you can do to tell those brain cells they have to work together again. You can't, we just don't know how to turn that part of the brain on and off the way we'd like to be able to. For an older child and adult who develops new strabismus, you will know, because then your suppression isn't working and you're going to report either strain or double or confusion with the world. And that will be a marker to me that there's progression or change. And anytime there's progression or change, it means go check the pressure again, go do the scan again if it's persistent. If it is just, for 20 minutes after an all-day Zoom, that's okay. That could be, it's much like the parent who wrote me this morning on the internet portal or on the medical record portal. My child, we won't provide any, who is an adolescent, spent the day on the computer yesterday doing schoolwork and had some, difficulty last night for 20 minutes of dizziness in her eyes that went away. And of course, that it's just a different world for many patients, including all of us. So strabismus surgery is done. It's not a universal, and I have a very high threshold myself for recommending it. Some of my colleagues are a bit more free with it. And the other reason I always am a little reluctant in young children is in many patients who have sensory disruption, basically the eyes are misaligned early, they cross young and then they drift out as they move through middle school and often drift out as a high schooler. And if we did surgery as an infant or as a toddler, we've pushed them out and then they drift out sooner or more later in life, meaning they get to have other surgeries. But that doesn't mean you let a middle school student go to school with their eyes looking at their nose. That simply is not a way for a middle school or elementary or any student to live their life. There's a lot of reconstruction issues for the kids there. All right, that was long-winded, Amanda.
But it was full of so much information. It really was. And it was interesting hearing you talk, you were talking about high pressure deviates the eyes in. Actually, Joe asked, can low ICP cause problems as well? And how does that present if somebody has low pressure?
So typically it doesn't produce eye muscle issues, but I think it could change what your I think that it could change your baseline alignment to some extent. Typically, low pressure doesn't do anything to the optic nerve as well. But of course, everyone has heard of the headache and other things from lower pressures. But generally, I don't think of hypotony in the brain causing a big problem on the eye side.
A couple of the adults who are watching, and I think a couple of parents have also messaged something around this theme, which is, there's been damage and we're trying to correct damage, but how much can you really correct? And we see some of the adults who have messaged in some questions and comments have said things like, I still, I have this, what is it? I can't drive for more than 30 minutes because my eyes strain and hurt. But the doctor's saying nothing's going on inside my head. Another 24-year-old wrote in and said, I have eye pain, my vision's bad, it's blurry from time to time, even though I wear glasses. So it could be indicative that something's going on with the pressures, but is there also lingering eye challenges that individuals with hydrocephalus might face because of damage that might not be fully correctable?
And of course, that's the case. What we should have said is that hydrocephalus causes those ocular motility issues, which once there are there for a lifetime. The other thing they do is the disease can cause damage to the visual pathway, and that can manifest as reduced vision or loss of visual field, or even Swiss cheesy kind of visual fields. And every patient is a bit different on that. And it may also reduce sort of our bandwidth. The optic nerve in a normal patient, say, has 1 million nerve fibers. And we can see 20/20 with 200,000 nerve fibers, just 20%. But they probably aren't seeing as well for all the day-to-day activities. A patient, for instance, who has occipital lobe damage may not do as well in a crowded environment as they do in a simple environment. And I think all of us can say there's a level of noise and activity that starts making us not able to function as well as we would like. So I think that everybody is asking that these lingering effects are in fact forever. Until we can learn how to replenish the optic nerve or get those nerve fibers to regrow correctly. But the first step is to get them to regrow at all. But then to get them to grow where they're supposed to will be the next step. But yes, I think unfortunately, there's a lot of legacy difficulty that goes on. And to some extent, that goes back to my, you have a high contrast visual acuity so that you can get the driver's license, but that's not quite the same for everybody. And some of us will be, race car drivers, and others will be more Cinquecento or some little car, that can patiently do right lane driving on the highway.
Yeah. Pam, I don't know if that fully answered your question. Your question was a little bit different. Do you want to follow up?
No, that's great.
Okay. I'm going to actually ask, we were talking about strabismus, and Chelsea brought up another condition, and I don't want to butcher it by saying it incorrectly. Chelsea, do you want to ask your question? Because this also goes with things kind of getting better over time. Is Chelsea still on?
Can you hear me?
Yes.
Yes. So my question was, my son has nystagmus in both of his eyes where they quiver. I was curious if that's something that with time as he grows, if there's a way to help that with therapy, or if it's just something he's going to have his whole life.
So Chelsea, thanks for that question, because we don't usually talk so much about nystagmus in the setting of hydrocephalus, although it can and does happen from damage usually in the brainstem area or the cerebellum. But when we look at nystagmus, which is, as you said, a quivering of the eyes, typically horizontal, it comes in congenital forms and in acquired forms. The congenital forms don't usually start in the delivery room, but are usually evident at 3 to 4 to maybe 6 weeks of life. And you could say, well, that's just the parents have actually been awake long enough to see it. But no, it really is that when the brain is trying to learn to put an eye on target, that's the development process. And when that goes awry, nystagmus is the result. As you implied, nystagmus reduces the vision, but it reduces the vision in a highly variable amount depending upon the cause. So in the United States, the two most common causes of nystagmus are optic nerve disease and ocular or oculocutaneous albinism, and all the variants of blonde to fairly complected that might not even fit the cutaneous definition of albinism. Most of, so that's, and then there are a smattering of retinal diseases that are rare. And in olden days, there used to be infections and other things that we simply do not see, fortunately, in the US. For instance, a patient with extensive measles, that is childhood measles and not rubella. There's acquired nystagmus, which could occur as a result of injury, a result of disease, a result of progression of the nystagmus, and I dare say, a bleed in the brain or something like that. For the congenital nystagmus children who turn into adults, they typically improve as they grow older. A few will reach near normal. Many will be subnormal. So when I say near normal, 20/40, even 20/30, with both eyes open, and could be as low as 2200. Typically, their periphery or peripheral visual field is normal. So they function in the world pretty well, but it depends on what their binocular acuity is, how they do in school, ranging from basically how much support they have. And many will drive and some won't. And it is one of those stories that the parents all hope to write before the 6-month birthday, and we don't usually write until they're 12 or 13 years of age. There is a higher proportion, perhaps, that need glasses, but you certainly would give them glasses earlier than you might others. But one caveat, that if you have a child with nystagmus or an adult with nystagmus, we typically measure visual acuity with one eye at a time. But for those patients, a binocular acuity is the most important representative functional estimate of how they do. And that will be up close and far away. And it's just because when you cover one eye of a patient with nystagmus, the nystagmus usually gets worse, and that causes the vision to decline. So it's always good, if you have such a patient in your care or you are such a patient, that you remind that clinician seeing you, could you measure the vision both ways, binocular and one eye at a time? And the other thing about the nystagmus, Chelsea, is that usually it's way better up close, so that they function much better up close. And you'll see that even in your infant, that she will do close-up vision and be really happy about it, and let her do that.
Great, thanks, Dr. Repka. I have Kristen, do you want to ask your question, Kristen? Because it's also a follow-up to a childhood eye condition that we see. Or I can ask it too, Kristen.
I can ask it. I'm just wondering about cortical visual impairment. It's more of a brain, it's a processing disorder, a vision processing disorder, as far as my understanding. Is that something that is normally diagnosed and treated by an ophthalmologist, or is it typically not something an ophthalmologist would, I don't know, be able to help with? I don't know.
Okay, well, there are a number of things there. First off, the diagnosis. Any of the eye care providers that we mentioned at the top should have some familiarity with the diagnosis. In terms of, who sees more of it, who does that, that's going to be just the same as who sees more of the hydrocephalus patients. But for instance, in my practice, cortical visual impairment is a very, very common diagnosis. But it is a wastebasket term. All it means is there's some injury or impairment to vision based upon a brain injury. And it could be transmission from the eye to the brain. It could be primary interpretation by the brain, for instance, that you only see the right world and not the left world. Or it could be the association areas or the part of the brain that does the interpretation. So it is dramatically varied in its presentation and its impact. It's highly crucial, though, for support services. That diagnosis gets support services that if you said, well, I'm not sure, then the patient gets nothing. So it probably is somewhat overutilized, and I think with reasonable merit. And it is a panoply of problems. Now, what do you do for management? So just like we mentioned VT before, we don't know if VT, we don't know if early intervention helps change the outcome. We certainly know that growing a patient, raising a patient in a non-stimulating environment would not be a good idea. But exactly what more you gain beyond the environment with the interventions is hard to know. Certainly in the children who are just delayed in development, it probably helps by encouraging them to use their system. Typically, though, Kristen, I would say it's also about adaptation of the patient to those deficits, understanding them and being able to work with them. Now, there are occupational therapists and physical therapists, and then low vision experts who sort of go around in this space. So I would say young people, it's about stimulating environment, making sure that the patient is aware that you're showing her toys and lights and, actively stimulating and not, running around trying to do your own Zoom call and the child, but not that anyone would. As we get older, it's going to probably require more of those other specialists, and those include the vision teachers for the visually impaired or for the blind. That would be very helpful. And there are programs designed, basically by making sure that it's a simple presentation. So the cortically visually impaired patient does better with simple presentations and not a lot of extraneous stuff, with figure legends and lots of other things. Simple is better to get over the point. And it will depend, for most patients here in Maryland, of course, we're used to these children going through an infant and toddlers or early intervention program, and then to preschool programs, either at MSB or not, and then depending upon what they do in their school system. For older patients, we use low vision experts. So in my department, Judy Goldstein is an optometrist who basically helps make sure that you're up to speed on all the latest devices or computer software that can aid a patient with vision impairment. Because those services are not available, they're available in the educational system until you age out, and then you need them in the medical system. So
that was part of where I was going with that question, is that we've had a hard time getting the services because we had a hard time getting the diagnosis. And the school did an evaluation and said, yes, we think he has cortical visual impairment, and we couldn't get the doctors to give us the diagnosis so the school could provide the service, even though the school did the eval that said, yes, he probably has it. So that was I was just being looped in circles between doctors and school districts and not getting access to services. So I was just wondering if there's if it's just because I was asking the wrong people the wrong questions. I don't know.
Well, you were probably asking the right questions, but I guess the wrong people, assuming there's something there to support. I mean, obviously one needs something to support a cortical visual impairment diagnosis. And on a hydrocephalus call, almost certainly there's something there to do that. But, again, that may go back to Amanda's first question, which was you may need help either from the pediatrician being directed or the neurosurgeon or the neurologist, because it's a history question largely. There are features of cortical visual impairment of, the crowding phenomenon, the preference for bright lights, the looking down. I mean, there are things that they do, but there are also things that the children don't do. They don't come in with the sign on them, but usually the parents give you enough, or at least the grandmothers give you enough to make the diagnosis when it's appropriate. Obviously, the imaging is helpful too, as support for it. And it is a shame that that's what the system does, but that's certainly true. I know the parents, that's what they struggle to get. And it's part of the reason I mentioned when testing visual acuity, I hate visual evoked potential visual acuities because they give everybody the false sense of security.
Well, thank you very much.
Thanks, Kristen.
You're welcome.
So this is going to kind of be a funny question, Dr. Repka.
I guess that's the usual story. There are no funny questions, right?
There's no stupid questions, right?
Okay.
Maybe this will be stupid. So I know a number of people with hydrocephalus, and of course, a number of people without hydrocephalus. Glasses seem to be pretty pervasive in our community. And so I'm curious, and do you see, in your opinion, if somebody has hydrocephalus, is there a really high likelihood that they're going to need glasses?
I don't know. There is going to be, first off, several things are going to happen. One is you're more likely to be seen by an eye care provider. And so you run the higher chance of getting glasses just from that. Maybe they're treating refractive errors that don't need to be treated in regular situation, but because the patient is slightly reduced, we'll try it. We also use glasses to control crossing. And crossing is more common in hydrocephalus, so that would be a reason. There are some syndromes associated with hydrocephalus that do have higher rates of refractive error. And so in some of those, like Crouzon's and some of the craniofacial conditions, there may be more likelihood of glasses. But it's an interesting observation. I certainly agree it's there. I suspect there are many reasons.
Interesting. Okay. I wanted to let Pedro ask his question. Pedro, are you still on? I'm seeing many different little boxes. And so, Pedro, you asked about retinal scarring.
Okay.
Let me and I'll just ask, because I don't think, is there a correlation between hydrocephalus and retinal scarring?
So, not greatly. Though there are several situations where it could occur. In some patients who get swollen optic nerves, they get little rings, which you could think of like bathtub rings, or that we would call high water marks. Or if you saw the sign on the bridge where it showed how high the water went. Well, you sort of get those created on the surface of the retina of patients with some patients with hydrocephalus. So I guess that could be a scar. The other scars are severe hydrocephalus or severe pressure increase could cause so much leakage into the retina, fluid, plasma, sugar, that it damages the retina in the macula, which is the part of the eye we see with. And when that heals, it could heal abnormally, leaving a scar, so a macular scar. And then, of course, the other group of patients with hydrocephalus are the preemies, who happen to have had hydrocephalus, but also had retinopathy of prematurity, whose retinas were treated with laser, and they have scarring. So there are some instances, but it wouldn't be a typical association.
Okay, and let's jump to our normal pressure hydrocephalus population. Do you see, somebody asked, Susan asked if there's an estimate of the percentage of normal pressure hydrocephalus patients that have vision problems. And we typically see NPH in individuals 60 and over. I have never seen a study, and so I'm curious if you've ever seen a study that has an estimate of the percentage, or if you just have your own thoughts on it.
Well, since I don't really see that age group anymore, I don't really have any current thoughts to answer that question. So I think when you get your next senior citizen ophthalmologist on, no, I think I just don't know. I think they have sort of non-specific complaints. It's a much more difficult diagnosis, as everyone knows. And because the pressure is normal, you don't see papilledema. So you're not going to see the swelling optic nerves.
Tiffany asked a really great question. We've been talking about different ways the eyes can be damaged. And is there any way to prevent further eye damage when you're living with hydrocephalus? Like, is there anything that a patient can do proactively for eye health?
So once that pressure is reduced, it's very unlikely to progress. But it's also unlikely if the structures to heal themselves other than that initial healing. In other words, we don't usually get better, but it is usually non-progressive. If it is progressive, that screams that the pressure is not controlled and we're missing it. And those are the patients that we've taken and put pressure monitoring devices in, and they've had to spend a few days in an ICU. Or that have multiple scans. And you have to say something is going on if there's progression.
Okay. At this time, we've exhausted almost all of the questions. There's one from Bethany. And then there's two that you and I spoke about earlier, Dr. Repka. Bethany, do you want to ask your question? And let's see if Bethany's on or if she's able to unmute.
See, is it here in the list?
Yes.
No.
Is it common to have intermittent extropia in those with hydrocephalus? And have you found that vision therapy could help? And I guess defining extropia would be probably good.
Okay, so wonderful question. I'm going to be in the same position. So intermittent exotropia is one of the two most common childhood strabismuses. It occurs in about 1.5% of kids. It is not overly common in hydrocephalic children. And the question is it simply due to disruption that was from the hydrocephalus, or is it possible that the patient had two relatively common conditions? And we don't know. It could be either of those. You manage it the same way. Typically, intermittent exotropia can be treated with patching, with glasses, occasionally with vision therapy, occasionally with exercises, and some of those patients will progress. Some of them will stay the same. A rare patient will get better. And then lastly, they will get surgery if it's particularly bad or they're declining in their control. So it is a common by itself. And so it makes it harder. Of course, the most common strabismus in Western children is crossing, which is the most common in hydrocephalus as well. So it's hard to know for sure where the association is there for the exotropia. But you would treat it the same way: maximize the vision, patch if the vision is reduced, glasses if needed. You can try exercises because at least there's some evidence, and then surgery if it's terrible.
And Dr. Repka, Bethany says, sorry, she could unmute, but her baby's a preemie. I don't know if that makes a difference.
So again, I don't know what age the patient is, and that might be for Bethany the one issue. Early onset in a preemie doesn't usually get better, but it depends. You just have to watch. The preemies do anything they sometimes want for a year. And so they might be crossing 1 month and they're turning out the next month. So, and part of that is they're growing so fast and they're myelinating nerves and muscles are beginning to function that were delayed. And so it's tough for the kids and for their parents. And she said she's doing some therapy. So I assume they're doing some visual stim to try and get the patient to use the eyes. And of course, that's the other thing. The preemies have to learn to use their eyes too, or the vision.
Yeah. We just had a really great question come in too. It's a nice follow-up. It says, I know you mentioned strabismus is a sign of high pressure. Are there any other signs to look for in terms of eye movements or different blinking if an older child might be experiencing high pressure?
Upgaze.
Upgaze. So
upgaze issues are common in infants, but also would be a marker for older patients for particular forms of hydrocephalus that are in the area of the fourth ventricle. And so it's basically a blockade right above the fourth. And so that would be the other one to think of. That's much less common than crossing.
Okay. And can subclinical seizure activity cause intermittent strabismus?
Probably. It depends on what part of the brain's involved. You can develop strabismus if you have a sensory involvement. In other words, you take away the vision inputs to help the brain line up the eyes. If the seizure disorder is in the brainstem, it could do it directly from the brainstem as well.
Great. So we're at 8:07 and it'll end around 8:15. So I want to give you some final closing words, Dr. Repka. And what I'd love for you to do is to give some advice for our parents who are on the call of young children, like what should they be doing on an annual basis, looking for, what are some great eye health tips? Then apply that same question or set of tips for teens to adults living with hydrocephalus. And then we will thank you.
Okay, well, I was worried you've had me talk for 1 hour and 7 minutes as it is. So I think first off, the standard eye tips for everyone, children or adults, is eye protection, just like skin protection. So hats and sunglasses are important, not for this year, but for 40 years from now, depending on how old you are, for macular degeneration, which is the most common cause of non-correctable vision impairment in the Western world. And it starts now. And so I tell that to patients who don't have this, whether they be young or old, and it can be done. It's not always easy. Of the kids and adults who are in some glasses, by the way, you're getting UV protection from the eyewear that you're wearing. And so the sun, the visible light is not as bad as the ultraviolet. But for the kids that don't wear anything, or the adults that don't wear anything, add those things as part of your sunscreen regimen for that protection. But that's now. For the other is, I think you do have to advocate, if you will, for the patient. I think everybody on this call knows that, otherwise you wouldn't be on this call. But you have to tell the other people you meet that they have to advocate for the condition. And I wish there was a better diagnosis to get services. That's one of the real legacy problems of the regulations that are in most states in terms of services. That one diagnosis seems to be preeminent, and then people aren't so comfortable with making it. So look for somebody that can help you there. And I think later in life, looking for low vision experts. I'm not the neuro-ophthalmologist. Even the regular optometrist isn't going to provide the expertise of the low vision specialist can, and sometimes working with some of the problems. They will also, by the way, often be the people doing driving evals or setting up driving evals for patients with neurological impairments. And so they're a good resource in terms of helping you navigate. And then lastly, visual fields. We didn't really talk about visual fields here because for the first 10 years of life, pretty much any visual field you do on the children is wishful thinking. But later on, it's really important to understand what the teenager can do, why they may be missing things, or for the adult, the same thing. And particularly if you're driving, to understand that your fields are okay or not okay. And you can sort of learn to work with that. Suppose I had a field defect to my left. I still fit the statutory requirements for driving, but I have a field defect to my left. So normally I would use the left side mirror, but I would want to be doubly certain that when I am driving, I learn to turn far to the left, much further than you would. And as you can probably afford modern cars with blind spot monitoring, this is the perfect population where it should be like a throw-in, even though it's not. But to supplement a skill and not make the mistake that could be hazardous to yourself or to others. And that's what the fields can tell us. The other thing the fields can do is, of course, overstate how good you are. And somebody mentioned it, distraction. If lots of stuff is going on in the visual field, you may miss because, again, you don't have the redundancy of the peripheral vision that you have without this history. So, and I guess mostly, having occasional care when it seems appropriate. And that's not by any means a shill for annual, because it's probably not necessary for a lot of teenagers and young adults, whereas it is for young children who are just growing. Obviously a patient who is not stable, then that needs help.
Wonderful. Well, I just want to thank you so much for joining us tonight, Dr. Repka. I learned a lot. I learned some new terms, some conditions I hadn't heard of. I hope all of you also enjoyed the evening and are able to take away some tips from Dr. Repka, but also some really great information from other parents and individuals on the call. And I hope that you can connect to people who were here tonight. If you heard people who were had questions that might peek at similar experiences that you're having, we can always, I'll try and help connect you as well. You can chat people right now before we close for the evening and share information, or we can see if we can help make some connections. We have people joining us tonight from Maine all the way down to Florida. And it's really wonderful to see so many familiar faces and to meet some new people. So thank you for joining us this evening. We really are happy to host these meetings for our community. If you have a topic that is of interest to you, a specialist that we can bring in, please chat it to us. On May 20th, Dr. Brandon Rock and myself will be doing a webinar on transition. It is for teenagers and young adults with their parents to attend together in person. And we will be talking about what you need to plan for and have ready and be thinking about as you transition your care from pediatric to adult care. And that really does start at the age of 14. So if you have a 14-year-old, I hope you will join us on that call. And Dr. Repka, again, thank you so much for being with us this evening. If we can all do everybody's on mute, so little.
Well, thank you very much. Thank you.
Thanks, everyone. And we'll leave the meeting open for a couple minutes in case people are chatting to exchange information, and we'll close it in a couple of minutes. But thank you, Dr. Repka. I hope you have a wonderful evening. Monica, it's great to see you. I see you over there.
Yeah.
Toddy, it's good to see you. I haven't seen you in forever. I get to see your daughter.
Thank you. I know I've been trying to do